Great. Thank you so much for the kind introduction. So my name is Angela Brijmohan. I'm a PGY5 cardiology fellow over at Queen's University, and I was a visiting elective resident at St. Mike's back in November. And Dr. Chow and I had a discussion about topics in the area of women's cardiovascular health, and this is an area that's interesting to me. It's on the topic of cardiovascular risk in women who have a history of gestational diabetes and hypertensive disorders of pregnancy, as well as the role of echo in helping to risk stratify these women in terms of long-term cardiovascular health. So I don't have any financial disclosures. This presentation is based on learning module toolkits and research developed from the Canadian Women's Heart Health Alliance. So the goal of this presentation is threefold. The first is to identify the concepts of unique cardiovascular risk factors in women. The second is to recognize and understand the mechanisms and how a history of gestational diabetes and hypertension in pregnancy can confer long-term cardiovascular risk. And the third area is to identify gaps in risk stratification and get a sense of how echo can contribute to help risk stratify women for closer monitoring long-term. So by way of introduction to this talk, we'll talk about traditional versus non-traditional cardiovascular risk factors. So we do know that traditional risk factors include a history of diabetes, smoking, obesity, physical inactivity, hypertension, and dyslipidemia. However, there's some emerging non-traditional risk factors that are unique to women and hit much earlier in life, often within their late 20s to early 30s. And that is a history of preterm delivery, hypertensive disorders of pregnancy, which includes eclampsia and pre-eclampsia, gestational diabetes, autoimmune diseases, breast cancer and their associated treatments, as well as depression and socioeconomic disadvantage. So the emerging non-traditional risk factors include preterm birth, which has been shown to be an independent risk factor for developing long-term cardiovascular morbidity and cardiovascular-related hospitalizations. The second non-traditional risk factor is hypertensive disorders of pregnancy. So this is pre-eclampsia and gestational hypertension, and this has been shown to impart a 3 to 6-fold increase in the risk of long-term hypertension. The third is gestational diabetes, which increases a woman's risk of developing type 2 diabetes by 7-fold later on in life. The other category is that of inflammatory disorders, which include rheumatoid arthritis and systemic lupus erythematosus. And these conditions have a higher rate of occurrence in women and increases the risk of MI by 2 to 3-fold. Similarly, lupus has been indicated to increase the risk of MI as much as 9 to 50-fold over time in the average population. For women who have had a history of breast cancer, radiotherapy for breast cancer has been shown to increase the risk of ischemic heart disease. Similarly, chemotherapies such as trastuzumab and anthracyclines increase the risk of heart failure over the course of a woman's lifetime. Thirdly, there's an index known as the Social Disadvantage Index, which combines social and economic exposures into a continuous measure. And the finding was that if someone had a worse social disadvantage, this was associated with a higher risk of cardiovascular disease later on in life. So to ground our discussion, we'll use a case study of Miss HT. So this is a 47-year-old female who's referred to your outpatient clinic for cardiovascular risk assessment. She has no traditional cardiovascular risk factors, is not on any medications, but on taking a history of her pregnancy course, you find that she has a history of gestational diabetes, severe preeclampsia with her first pregnancy at the age of 36. Her blood pressure in clinic is 135 on 75, and her fasting lipids show an HDL of 1.05, LDL of 3.8, and her A1C is normal at 5.4. So with that case in mind, we'll think about these 4 questions as we move through the presentation. What is her 10-year Framingham risk score? Is her Framingham risk score sufficient to reassure her? And what are the impacts of gestational diabetes and hypertensive disease of pregnancy on her future cardiovascular health? And how should she be screened earlier to reassess for premature cardiovascular events? And we'll discuss the role of echo in screening women earlier for premature cardiovascular disease with this history. So some definitions. Gestational diabetes is defined as new glucose intolerance that's diagnosed during pregnancy. There are several tests to do this, one of which is the 50-gram glucose tolerance test, with a finding 1 hour postprandial of a blood glucose of 11 or higher. The second test is a 75-gram oral glucose tolerance test with a 2-hour postprandial greater than 9 or 1 hour postprandial glucose greater than 10.6. This is relevant because it's quite common and occurs in about 3 to 20% of Canadian pregnancy, with a higher rate of occurrence in women who have an older age at time of first pregnancy. Hypertensive disorders of pregnancy are a spectrum of diseases. It includes gestational hypertension, which is de novo maternal hypertension with a blood pressure of 140/90 that occurs after 20 weeks of gestation. It also includes pre-eclampsia, which is more severe, so it includes the de novo maternal hypertension, plus evidence of end organ dysfunction, such as proteinuria, and hematological complications, neurological symptoms, and early signs of uteroplacental dysfunction after 20 weeks of gestation. Eclampsia is everything that's encompassed in preeclampsia plus seizure and is a medical emergency. And HELP syndrome includes all of the above, in addition to hemolysis, elevated liver enzymes, and low platelet counts. The prevalence of this spectrum of disease occurs at a rate of 2 to 10% of all pregnancies. And just having a history of preeclampsia confers a higher rate of cardiovascular disease across the spectrum and increases the rate of cardiovascular disease, coronary artery disease, stroke, and peripheral vascular disease 2 to 3-fold. So the CHAMP study elucidates this further. So it's a population-based retroactive cohort study that showed that maternal placental syndromes, which include preeclampsia, gestational hypertension, placental abruption, and placental infarction, increase the risk of having future cardiovascular disease by 2-fold. This is important because maternal placental syndromes are seen in 7% of all deliveries in Canada. And the mean age to onset after that delivery for a woman to have her first cardiovascular event was at age 38 years. There's also a dose-response relationship for having a history of maternal placental syndrome to the severity of the cardiovascular disease. For example, if it's more severe of a placental syndrome, such as that resulting in intrauterine fetal death, the risk towards the mother's cardiovascular disease is 4-fold higher. And this study from the prospective evidence from the Child Health and Development Study cohort elucidates this further, showing that if a woman has a placental event or preeclampsia at less than 34 weeks, which is considered more severe preeclampsia, this conferred almost 10-fold higher risk for her cardiovascular mortality down the line. Outside of the months around having preeclampsia, having a history of preeclampsia increases the risk of coronary artery obstructive disease, specifically with myocardial infarction. So the Genesis proxy study was a prospective, multi-center Canadian study that showed that women who presented with their STEMI had a much higher rate of a history of preeclampsia than in women who had prior normotensive pregnancies. And this highlights that hypertension, disorders of pregnancy, and gestational diabetes are a unique and comparable risk factor to some of our traditional risk factors, such as smoking and diabetes. So this table highlights that the effect estimate for someone with hypertension in pregnancy ranged from anywhere from 1.2 to 16.9 in terms of future cardiovascular risk, depending on the severity of the hypertensive disorder. So this is quite comparable when we look at the hazards ratio of smoking, diabetes, and hypertension compared to the non-traditional risk factor of gestational diabetes and preeclampsia. They all fall within similar range. And this highlights that when taking a history for women in the clinic who may be coming in for a well woman clinic, it's important to, in addition to smoking and diabetes, ask them about their history of gestational diabetes and preeclampsia because it confer comparable risks. So what is it about preeclampsia that leads to higher risks of MI and cardiovascular disease down the line? Well, there's two theories about this. The first is the stress test theory that views preeclampsia as a major stress test that unmasks cardiometabolic risks that would have otherwise come to light later on in life. The other hypothesis is the causal role hypothesis, which highlights that endothelial dysfunction that affects both the placenta as well as the endothelial lining of the blood vessels are at play and lead to a state of hypertension. It would also increase rates of placental disorders, placental abruption. This is an area of active research, so it'll be interesting over the next coming years to see what that relationship actually is. So, what does this mean in terms of management strategies for these patients? So, the first is to identify the unique risk factor profile of women who have a history of gestational diabetes and hypertensive disorders of pregnancy. And then we would have to reassess how our traditional risk factor stratification tools apply to them. We might have to consider doubling the risk that's calculated or just moving them up a class if they have these histories of gestational diabetes and hypertension. The next will be lifestyle measures, including diet, exercise, and smoking cessation, and pharmacological strategies in terms of considering starting a statin therapy earlier, even if their LDL does not meet the classical targets. So we'll go back to the case study of Miss HT. So, based on her blood pressure, her history of no traditional risk factors, her lipids, she would actually be classified as low risk based on the Framingham risk score. However, we know that because she has a history of gestational diabetes and her preeclampsia, her risk of future cardiovascular disease could be up as 10 times higher than what is reflected in her current risk estimation from the Framingham risk score. Other tools that are available for specifically looking at risk stratification in women include the Reynolds risk score, and it includes age, biological sex, systolic blood pressure, smoking status, cholesterol levels, family history, CRP levels to risk stratify women into low risk, borderline risk, or elevated risk. But even then, even though this model was determined to re-stratify women into higher risk factor groups, it doesn't account for their pregnancy history in the score. So that brings us to the role of echo and helping to identify patients who are at higher risk of long-term cardiovascular dysfunction when they have preeclampsia. So In contrast to women who have peripartum cardiomyopathy, which presents with left ventricular systolic dysfunction, women who have preeclampsia actually present with diastolic dysfunction and have relatively preserved systolic dysfunction. So the diastolic dysfunction is a predominant finding, and it actually occurs in up to 40 to 50% of severe cases. And it's on assessment shows up as reduced E prime velocity, increased E to E prime ratio, reflective of elevated filling pressures, reduced E to A ratio. It also shows that in even women who don't have severe preeclampsia, there is evidence of structural remodeling. And there's an increase in the LV mass index and relative wall thickness, as well as evidence of concentric hypertrophy, who that's observed in 16% of patients with severe preeclampsia, and up to 30% of patients who have just run-of-the-mill preeclampsia. There's other evidence of left atrial enlargement, and even beyond the assessment of diastology, evidence from global longitudinal strain, which is a more sensitive measure of contractility, shows some signs of impairment in patients who have preeclampsia. So this usually occurs within the last 6 months of 6 weeks of pregnancy and into 3 months into recovery, but they certainly can persist longer, and especially in women who have severe preeclampsia, these findings of diastolic dysfunction can persist into greater than 1 year. This is important because in patients who have this diastolic dysfunction and a higher risk of persistent hypertension collectively can be at higher risk of heart failure with preserved ejection fraction down the line. In terms of long-term risks, a history of having diastolic dysfunction in a woman's first pregnancy serves as an early marker for higher risk for severe preeclampsia and worsening outcomes in future pregnancies. So there's no clear guidelines here about how women should be screened in terms of the use of echo if they have preeclampsia, but I think that this data so far points to if a woman is identified with preeclampsia, having a baseline echo taken at the time of their diagnosis and monitored for resolution of diastolic function over six months to 12 months would be helpful to see if their diastolic dysfunction improves. And if it doesn't improve and they end up developing HFpEF, then they would be closely monitored and it would be factored into counseling in terms of the safety for future pregnancies. So just to take stock of what we discussed today, so we identified the concept of unique cardiovascular risk factors in women. We had a discussion about the underlying mechanisms in terms of how endothelial dysfunction can confer higher risk of preeclampsia, hypertension, and placental disorders. And then we identified gaps in our current risk stratification tools and how they can often underestimate a woman's cardiovascular risk. And we had a discussion about how echo can identify diastolic dysfunction in women with preeclampsia and how serial echo, whether at 6 months and 12 months, can help one, assess for recovery, and if there's no recovery, it can inform discussions about long-term monitoring as well as the risk for future pregnancies. So I just want to acknowledge that a lot of the work that went into this presentation was supported by modules, learning tools from the Canadian Women's Heart Health Alliance and Dr. Kajeni. I've left the website there for anyone who's interested. There's a great atlas and lots of modules on the topic of women's heart health. And these are my references. So thank you for your time today, and I'd open up the floor for any questions.